Hi class, my name is Amber. I'll be discussing chapter 19, which is behavior disorders. The book jumps straight into the type of disorders, but a behavior disorder is actually a difficult one to define. We define it as a functional disorder or an abnormality. We usually relate it to conduct. Treatment is normally sought out for children, but it can be found in adults. Um, It is the reasons or causes are normally biological factors, sometimes family, social, or school related type factors. Um, it can be caused from like a physical illness, malnutrition, brain damage, heredity factors, and so forth. We're actually going to discuss several different disorders. The first one will be depression and the different forms of it. We're also going to discuss some different types of anxiety, eating disorders, the attention deficit disorder or the hyperactivity disorder, and pervasive developmental disorders. With depression, depression is an emotion that's characterized by feelings of sadness, low spirits, being gloomy, disappointment, frustration, dejection, things like that. Depression can be caused or the response of a loss of a life, frustrations, disappointments, things like that. Here we have a map of the United States. And this was some research done back in 2008 for the adults that actually meet the criteria for depression. And you can see, take a moment and look at the state that interests you. As you see, we're fairly high over here in Nevada. We also have clinical depression. I think the book kind of doesn't clearly state what is what, but under clinical depression, it's known as the common cold of psychiatry. It has the highest lifetime disorder at being 17%. We will see an average age of about 40 years old for the onset of clinical depression, and obviously it occurs with morbidity, mortality, and disabilities. Clinical depression is seen with certain socioeconomic factors like single parents, economic deprivations, unemployment, things of that sort. The symptoms are associated with physical disorders such as multiple sclerosis or encephalitis, systemic lupus, or the chronic Epstein-Barr syndrome. On organic disorders, you'll see clinical depression with tuberculosis or electrolyte imbalances, maybe some kind of vitamin deficiencies. And obviously, you're going to see pharmacological agents that will cause clinical depression symptoms, things like beta blockers, antiarrhythmics, and estrogen. We do have some theories about depression. We have the psychodynamic theory, and basically depression is associated with perceived differences between the ideal self and what the person actually is. They have a loss of sense of well-being, and the depression can be a signal to alter psychological behavior. This theory, it's thought if this is left unchecked or untreated, it's going to lead into a deeper depression. Behaviorist theory believes that depression is a learned helplessness. They have a negative outlook on the present and the future. It's an internal attribution of the uncontrollable outcomes, whereas the cognitive theory is a depression as a result of impaired cognitive function. In other words, they feel like they have no control of their life, but they believe they've given it multiple attempts and eventually they give up. We have what's called reactive depression, and reactive and preparatory depression are actually related to the grieving process. Reactive depression is the response to past losses, whether it's financial security that's lost, a job, a lifestyle, where preparatory depression is losing loved ones, objects, things of that nature. We have a subcategory of depression under bereavement, and this is characterized by the feelings of depression and related symptoms like loss of appetite, insomnia, weight loss. Though this is natural and normal, it's something you do need to watch. During this period, people have a tendency to feel extremely guilty. I should have done this, I should have said that, whatever it may be. Environmental stressors are associated with major depression. We also have dysthymic disorder. It's a persistent mood state, but more chronic than major depression. It's characterized by long-standing mild or moderate depression, but again, not as severe as major depression. In this category, basically, people are going to say to you, I've felt depressed all my life. They have very low self-confidence, hopelessness. There's no difference between the male and the female. You'll see 5 to 6% of the population be diagnosed with this disorder. You'll see signs of constant complaining, blaming themselves and others. Obsessive traits are noticed. And alcohol and drugs are very common with this. The diagnosis depends on the severity of the symptoms. Usually you want to see the symptoms for about 2 years in adults and 1 year in a child. Major depressive disorder affects millions of people every year, 20 to 25% of them being females and 7 to 12% being males. The primary onset is about the age of 40 years old, and 50% of the people diagnosed with this disorder are very likely to experience another quote-unquote episode. It is characterized by a 2-week history change from their previous life, so a dramatic change for 2 weeks versus what they were doing before. And they like to find 5 of these 7 behaviors occurring: insomnia or hyperinsomnia, a significant loss of weight or a gain of weight, psychomotor agitations, the feeling of worthlessness, the excessive guilt, recurrent deaths about dying. In this disorder, the healthcare provider should be on the lookout for suicidal attempts. If you have this diagnosis and they're discussing death or suicide, normally they hospitalize the person immediately. We also have postpartum depression. This isn't totally abnormal. It occurs with 80% of women after giving birth to a child, and they can feel mildly depressed for a couple weeks prior to having their baby. 10 to 15% of them actually experience full postpartum depression. Very similar to major depression, except it happens within 1 month of the birth of their baby. It does have several risk factors, being previous postpartum depression, no social support, histories of miscarrying, obviously a psychiatric history, and not breastfeeding is considered a risk factor. Postpartum depression is commonly overlooked by healthcare providers. What they should be looking for is appetite, changes in appetite, changes in sleep, mood. Are they bonding with the baby? Are they having guilty feelings and not taking care of the baby? Several different forms of treatment: cognitive behavior theory, family or group therapy. And if it's a persistent depression, obviously there are medications. Under depression, we have bipolar disorder. Bipolar actually is almost used as an adjective. It does have a social stigma that can actually hinder the process of diagnosis, because people can recognize that they are having these issues but fail to report them or try to hide them due to the social stigma of being bipolar. It's a cyclic mental illness. We see it peak between the ages of 15 and 19 and 20 to 24. I'm not really sure why it doesn't say 15 to 24. It's characterized by mood shifts, hypomania, episodes of major depression, and mania. There are two types: bipolar 1. It's equally found in males and females. Its prevalence is 0.4 to 1.6%, and it's categorized by episodes of mania and depressive episodes, where being bipolar 2 is most common with females, at a prevalence of 0.5%. And this is characterized by hypomania episodes and depressive episodes. Just an FYI, hypomania is a mild mania. It's extremely energetic, very talkative, very confident, creative, productive. It's considered a very troublesome mood when they are partaking in risky behaviors, whereas mania is an abnormal energy level, easily elevated irritability. It's very obvious at times. To manage bipolar disorder, we have to recognize the symptoms. We have to get a diagnosis. You find many of them, they self-medicate using street drugs. So that's something to look out for. They'll therapeutic communication, in other words, let them know, hey, look, we need to know what's going on. Well, it's okay to treat this. It's okay to be this. There is treatment for it. Very important that they have proper calorie intake, proper sleep, their diet, nutrition, no caffeine, so forth and so on. Helps manage the disorder. Be on the lookout for suicide again. You have the major depressive symptoms here, so suicide is a big thing to watch out for. Now we're going to move on to anxiety disorders. It's not on the slide here, but I'm just going to discuss a little bit of the general characteristics about anxiety. We all have a form of anxiety at one time or another. The author of our book actually says that sometimes you have that headache, the sweating, the tightness in your chest, the heavy breathing. They're normal symptoms and feelings that can be beneficial, providing a heightened sense of self that allows for higher mental functioning and enhanced performance ability. So, anxiety can be normal, given the situation. But there's many anxiety disorders, including the panic disorder, the agoraphobia, social phobia, social anxiety, OCD, PSD, so forth and so on. When it comes to anxiety, it's a little more tough to diagnose, because the symptoms of anxiety can also be symptoms of an endocrine problem, symptoms of a gastrointestinal problem, side effects of medications being taken. So they do have a couple of rating scales, one being called the Beck Anxiety Inventory and Hamilton Anxiety Rating Scale. Questionnaires, helping to find out the specificity of it, helping to find out the sensitivity, helping to trying to figure out, is this related to a medication? Does this person have any other issues that are being masked by looking like symptoms of anxiety? The first one is the panic disorder. It's an unknown origin. It usually shows up late adolescence, early adulthood. It's reoccurrent, unexpected attacks, one followed by a persistent concern, fear of another, continuing to change your behavior because of this panic attack, worried about the consequences, constantly worried about it reoccurring. Usually it happens for 20 to 30 minutes, but not longer than an hour. You're going to have an increased heart rate, sweating, shaking, dizziness, difficulty breathing, things such like that. The treatment of a panic disorder is obviously medications. Avoid caffeine, cold medications, nicotine, alcohol. Stay on a consistent schedule. We have agoraphobia, which is avoiding a situation where you know you're going to feel anxious. So if you know that walking to a crowded auditorium is going to make you feel anxious, it's going to provoke a panic attack, you're going to avoid that place. You're going to avoid that situation. You're going to go around it as much as you can. These can happen with panic attacks or without. Most of the time, they also do get panic attacks, but it is possible to have the mild anxiety without having a panic attack. These people make some serious adjustments to their life to avoid wherever it is they feel anxious, whether it's traveling away, whether it's their work, whatever it is, they will make extra effort to avoid being in the situation. Then we have our social phobias and our social anxiety disorder. It's an irrational fear of humiliation, failure, or embarrassment within public attention, within public eye. The symptoms include blushing, heavy sweating, nausea, trouble speaking, and then in severe cases, they get extremely anxious. It can lead to a panic attack. Again, people like this will avoid any type of social situation, whether it's, occupational, having a relationship. It interferes with their life as a whole. On this slide, click on the YouTube video. It works on my end. I attached a link to just in case. It's a 3-minute video about specific phobias. I just figured you were tired of hearing me talk and I was giving you a break for a minute. As far as OCD, obsessive compulsive disorder, we all hear this. This is another one we almost use as an adjective. Obsession, it happens equally between men and women. It begins in adolescence or early adulthood. This disorder can present as obsession, irregular, intrusive, anxiety-producing thoughts. Things like they fear hurting others, contamination. The ultimate example of this is someone that washes their hands constantly. And then they'll turn around and question whether they did it or not. Did I wash my hands? Walk out and wonder, was it good enough? Did I do it? So they're obsessed. And then you have the factor part of the compulsion. A conscious, standardized, recurrent behaviors. It's, again, back to the repetitive hand washing, counting, checking. Tension stressors occur if the behavior isn't completed. If it's not completed properly, it's unreasonable to the performer. They stress out about the fact that maybe my hands I can't wash my hands. They weren't washed good enough. Things like that. The OCD is the most chronic of all the anxiety disorders. Patients will plan their routine to make sure they're able to perform this behavior. A lot of complications of OCD. It goes hand in hand with major depression and again another self-medication with substance abuse. And our next anxiety type disorder is acute stress disorder. It develops following an actual event or an observation, a threat, someone, a mugging, stuff like that. They get this fear from the event lasting 2 days to 4 weeks, causing an impairment, scared to go back to the subway that they have to take to work every day because they were mugged there, type thing. If you want to make sure you catch this type of disorder before it leads to the post-traumatic stress disorder, which I'll discuss here shortly. Those symptoms are usually after a month of the actual event occurring. The symptoms you'll see is dissociative symptoms, re-experiencing, replaying, reliving the event in their mind, avoiding things where it's disturbing their life, the anxiety they feel. Diagnosis on acute stress disorder is made by a timeline and the symptoms. It needs to be causing the impairment in a lack of functioning of the person's social life and occupational life. Generalized anxiety order, the most commonly seen disorders from a primary care physician. It's characterized by excessive worrying, anxiety of daily events. This excessive worrying, anxiety, and impairment goes for longer than 6 months. These people are what you might have described as uptight or a worrywart, things like that. This is a real disorder. They often present somatic symptoms such as difficulty sleeping, irritability, headaches, general fatigue, muscle aches, pains, etc. Post-traumatic stress disorder. This is very similar to that acute stress disorder. Difference is, again, the timeline. The symptoms usually start to occur after, sometimes like I said, normally within a year. It is stemmed by natural disasters, sexual assault, major accidents, violence, threats. Anything like of that sort can result to the post-traumatic stress disorder. And the symptoms we're going to see is severe concentration difficulty, helplessness, fear, headaches, numb to emotions, irritability. Again, intense fear. The patient's impairment can actually be from mild to severe, and you usually see the fear continue longer than a month after the actual event. There's self-defeating behaviors, including substance abuse and sometimes suicide, to help alleviate the pain that these types of patients feel and recall. There are ways to manage this. Sometimes you don't know where it's coming from, so we need to find out what's causing the patient the anxiety. A lot of the times they're treated with the list of medications here, the SSRIs, the benzodiazepines, MAO inhibitors, beta blockers, and again, group therapy, one-on-one therapy, things of the sort. Our next disorder under behavior disorders is the use and abuse of certain substances like alcohol, hypnotics, amphetamines, and so on. And this type of use is considered a high risk behavior. Well, what they do is they characterize the substance use and abuse into 3 different forms. First, you have the mild and least life-affecting, which is a substance intoxication. These type of people are those that are high-risk users who have a tendency to overuse. They've not developed any type of negative consequences from the use of their drug yet. The users have a wakefulness and disturbed perception, attention, thinking, judgment, psychomotor behavior, and interpersonal behavior. Their symptoms last for hours up to days, and they can have some type of withdrawal issues. Your next one that has experienced negative consequences are substance abuse. Sorry, these confuse me. Substance abuse. What's happened here is they have had negative consequences from the use of the drug. Despite the negative consequences, they continue to use the substance, and they start failing to meet work obligations, family obligations, life obligations. They'll start partaking in behaviors such as drinking and driving, or being under the influence. But it's not quite led into a dependency yet, where those that are severely afflicted are under the substance dependency, which is the ones that are going to commit the crimes to get the drugs that they need. Obviously, it's had a severe negative impact on their lives, and that doesn't really matter. They have a need for a higher amount of the drug, a different kind of drug. They have developed a huge tolerance. These type of people, despite the issues or recognizing, they cannot stop what they're doing. You need for diagnosis, you actually need the physician to be quite honest about that they feel the patient is unmotivated to change their behavior. The physician has to be, it's quite challenging to diagnose this. A lot of times they use what's called a CAGE survey, which I have a copy of it on the next slide. It's a questionnaire to categorize where the patient's abuse problem lies. This is the CAGE questionnaire. When I Googled it, they actually, it was more specific for alcohol, but they have the one that is modified for including drugs. So the question in there, it's done on a point system. Have you felt you ought to cut down on your drinking or drug use? Have people annoyed you by criticizing your drinking or drug use? Have you ever felt bad or guilty about your drinking or drug use? Have you ever had a drink or use drugs first thing in the morning to steady your nerves or get rid of a hangover? If you answer yes to 2 or more of these questions, it's positive and they recommend further evaluation. So how do we manage substance abuse? Well, I think we've all heard that we can't help someone that can't admit they have a problem. So that's really the first step, because substance, people that have relied on, are substance abusers. They have resorted to the use of substance abuse to not deal or cope with certain situations. So to change that behavior is extremely difficult. But the healthcare provider, the physician needs, assesses the patient, needs to be encouraging. You can change this behavior. You need to want to change this behavior. Here are the, explain to them, again, patient education, explain to them why they shouldn't be doing it, the effects of it. But you also have to offer some kind of support, some self-help treatments. I just randomly looked up a few numbers. These are for local. These are just 4 of many of them that are out there locally to help someone for self-help treatments. But you also have the Alcoholics Anonymous, Narcotics Anonymous, Marijuana Anonymous, the Cocaine Anonymous, all these different types of groups to help these type of people. These things are good to know, to offer, because someone will open up to and say, hey, I do want some help. I was just showing you how easy it is to get this information and to pass it on to a patient that may ever need it. Now, a little change in pace. Another behavior disorder is eating disorders. Anorexia, bulimia, binging, purging, so forth and so on. Though they say that of our population, more than 2% have some kind of eating disorder, we see it more between obviously females, and between the ages of 18 and 21. Our book states that, because of the body image that we have put on young women nowadays, these disorders actually date back to ancient Roman times. So the disorders themselves aren't new, but yes, we do have a higher prevalence of them than we used to. With our eating disorders, though, all of them actually can be life-threatening and cause psychosocial issues. We have anorexia nervosa. Anorexia is an eating disorder characterized by the intense fear of weight gain. It's an ongoing pattern of self-starvation and preoccupation with food and losing weight. Some major signs that you'll see are a person with their weight is below the 85% of expected weight. Women start to actually lose their menstrual period. They're in self-denial about their true self-image, obsessed with their body image. You'll see these type of people excessively exercising, super active. You'll actually get the growth of body hair, loss of, the hair on your head. They'll be very cold, low pulse rate. You'll see them get very nervous with meal times. They play with their food. They cut into small pieces. They isolate themselves from family and friends. A common characteristic of these types of people are perfectionists. They're very highly self-critical, and again, compulsive cleaning, compulsive exercising, and anorexia people tend to go through different episodes of binging and then purging to maintain their, that fear of weight gaining. Bulimia is an eating disorder that is, as we know, they binge eat and then they force themselves to vomit. A lot of them will overuse diuretics and laxatives as well. You'll see the fear of the inability to stop eating at their own free will, frequent vomiting, their periods are off the wall, swollen glands. These type of people have a lot of weight fluctuating. Secret behavior, secret food stashing, things like that. Their physical appearance is puffy in the face, a lot of bursting blood vessels, enamel erosion on their teeth, esophagus damage, internal bleeding. These people, again, self-critical, perfectionists, they will go through excessive measures to lose the weight. And then they say that they'll actually do stealing of money to buy food for binging. Binge eating by itself is also a disorder. We all know binge eating is just eating and eating and eating a whole lot in a short period of time. But the binge eating disorder has an emotional aspect to it too. These people will binge eat and they'll hide and eat, and they'll eat more. Really what it is they eat a whole lot more than what a normal person would eat. They hide it. and they won't be hungry, they can't stop, they never feel full. But then they go through the emotional part of being embarrassed, feeling guilty. They make it a point to eat alone because the amount of food they eat, because they're embarrassed. These type of people, you'll see a huge fluctuation in their weight, and go hand in hand with depression, anxiety, self-loathing, and interpersonal sensitivity. It's kind of a rapid circle for these types of people. They know they shouldn't be eating, but they can't control what they're eating. They feel terrible about it during and after, but they can't actually stop. So rather than words, here are a couple of charts. Obesity is also a disorder. It affects 30% of Americans. As you see on this chart here, the percentage of population older than 15 with a body mass index greater than 30. And USA is right on top of there at number 1. Obviously our diet leads to that, but there's other contributing factors that this little chart explains to us. Fast food, lack of exercise due to computers, tablets, cell phones. Fast food is also a higher fat intake, soda. People aren't eating like they're supposed to. People don't eat breakfast in the morning and then eat a whole lot at lunch. Poor parenting, daycare. People reward their children or themselves with food for whatever reason. Video games, vending machines. Convenience makes us fat. It's kind of, I think all of us can understand why that is. Another behavior disorder we have is the attention deficit or hyperactivity disorder. It is considered a neurobehavior disorder. It's characterized by children who present a combination of 6 or more symptoms of inappropriate inattention, hyperactivity, or high impulse. This is prior to the age of 7, and it includes significant functional impairment, and these lead to the need for a diagnosis, treatment, and management. The diagnosis is shown with a significant impairment in social, academic, and/or occupational functioning, and they like to see 6 months. They see these symptoms within the 6 months in 2 or more settings. There are 3 subtypes of ADHD. You got the category of the predominantly hyperactive impulsive, which include the inability to remain seated, fidgeting, climbing and running at inappropriate periods, difficult in participating in activities quietly, and the behavior can be described it's driven by motor, excessive conversation and speech, the inability to wait for a completion of a question before providing an answer, problems with taking turns, unwanted intrusion and interruption of the conversation or activity of others. With the inattention, including failing to give attention to detail, the inability to maintain attention, not listening when directly spoken to, failure to follow through on instructions. This includes homework or other assigned tasks, disorganization, avoidance or dislike of activities that require maintained concentration. The management of ADHD is that these symptoms are recognized immediately. Each, I have to say, child is treated on an individual basis, and not all their symptoms are like the next. We also need to take into consideration that home life, the caregiver, and the educator need to work together with this particular child. These children usually require behavioral therapy. for positive reinforcement, interventions in the home and the school, and medications can be useful tools in help managing the child's behavior. The recommendation for children with ADHD is a combo of the medication and the behavioral therapy. And again, patience with these children. With all these combined, a child can become a successful student, and a successful part in our society. Our last behavior disorder to be discussed are the pervasive developmental disorders. These are a group of conditions that have delays in development of the basic skills. You will see things like impairment of social interaction, disturbances of communication, repetitious behaviors, and all these are used for diagnosis of a pervasive developmental disorder. We all know and heard of autism. Autism is 4 to 5 times more likely in boys. It's initially difficult to determine the difference between autism, the diagnosis of autism, to a mental retardation. The difference is that an autistic child lacks affection. Mental retarded child can still be very loving, still be very affectionate. Autistic children have instability in their moods, get very angry. So it's important to maintain a constant environment for an autistic child, to maintain a specific schedule, a very stuck to routine. The diagnosis of these show up with missed milestones. A lot of the times they're just not where they should be, and a lot of the times your primary care physician or your child's WellCare checkups, these things become obvious. It's important to have these disorders diagnosed before the age of 3. Rarely are they diagnosed before the age of 1. Asperger's syndrome is the mild form of pervasive developmental disorder. A kid won't have a language delay or any type of impairment of any cognitive ability, but they lack adaptive capabilities. Very impaired with social functioning, and it's not because of lack of attempts, but there's a lack of ability to understand normal social cues. These children often have a preoccupation with some subjects and find it hard to talk outside this area. They are awkward and impaired in their ability to have a normal give-to-take conversation and have trouble developing peer relationships. Again, the management of any of these developmental disorders is early diagnosis. They go straight to the use of pharmacological agents. The risperidone is what is recommended by the FDA, but they also can use antipsychotics and SSRIs. The next best management of these types of children is education. Education to the caregiver, education to the educator, the school, the brother, the sister, the aunt, the uncle. It makes it for a less stressful day for these types of children. Here, this is from the National Comorbidity Survey, and it includes some disorders that we didn't discuss, but the majority of them are here, and it just discusses, just kind of shows the percentage of the population that will suffer from it in their lifetime, the average years until treatment. Very interesting. This is our mental health survey from America. So just take a look at that. This is a nice little graph for child and adolescent depression. The purpose of this is to show you that when these are diagnosed as children, I know I didn't get too far into adult and children, and because all these disorders can actually be studied and learned about far beyond the capacity of this textbook, but this goes to show you that a lot of these disorders actually overlap. And like at the bottom, childhood depression, more likely to also have an OCD and Tourette syndrome, panic disorder, anxiety, ADHD, the behavior disorder, bipolar. It just goes to show you how they are actually overlap each other in some way or another. I just thought this was some interesting information. So that's the end of my presentation. I hope you guys are all awake. This chapter is extremely detailed in some aspects, and others didn't give you much detail. So I hope I explained it well, and everybody have a good day. Thanks.